Hello, welcome to Wellness and Wisdom with Dr. Nadu Tuwakli, the podcast dedicated to empowering women over 40 to age gracefully, competently, and beautifully. I'm Dr. Nadu Tuwakli, a family doctor, preventive medicine specialist, author, teacher, mother, and expert in hormone replacement, anti-aging, and longevity. With decades of experience as a physician and as a woman embracing every stage of life, I'm here to share practical advice, expert insights, and inspiring stories to help you thrive in happiness, health, and appearance. Together with my guests, we'll explore topics that matter most to you, from navigating perimenopause and optimizing your health to redefining success in retirement and beyond. Let's celebrate the aging process with vitality and purpose, because your best years are still ahead. Subscribe now to add more life to your years and step into the best version of yourself. Welcome back to Wellness and Wisdom with me, Dr. Nadu Tuwakli. I'm joined today by Dr. Catherine Benziger, a board-certified cardiologist and medical director at Heart and Vascular Research at Essentia Health in Duluth, Minnesota. Cholesterol has been a hot topic for several years. A lot of people don't understand what their numbers mean or why it's important. And so today, Dr. Benziger is going to straighten up everything for us so we understand completely what cholesterol is, why it's important, what those numbers mean, what we can do about it, and obviously prevent heart disease, strokes, and damage to your blood vessel system. Without further ado, I'm going to welcome back Dr. Catherine Benziger.
Thanks so much for having me on.
My pleasure, and thank you for coming again. So, as I said, cholesterol has been a hot topic for several years. And why is this the case? Why do we even care about it?
We have known for a very long time that in addition to high blood pressure, high cholesterol are really the leading causes of heart disease and stroke, and they continue to be a problem among many, many Americans. We have done a better job over the past 20 years of recognizing high cholesterol, and we have more and more medications that are very effective at lowering the cholesterol, but it still is a leading cause of heart disease and stroke in the United States and globally.
So can you explain to us exactly what cholesterol actually is and why the body even needs it?
Well, cholesterol is essential for some of our body functions, and it's a very useful molecule for cell membranes so that we can digest foods and fats that we eat. It's good for certain steroids that our body makes. It's good for the myelin sheath, the coating around the nerves. There's a lot of good functions that cholesterol serves. But what we're measuring usually when you go to the doctor's office, you get cholesterol labs checked, are a couple different numbers. You have a total cholesterol number. You have a HDL cholesterol or high density lipoprotein, which is your good cholesterol. And you have a low density lipoprotein or the bad cholesterol, and then triglycerides. And what we're seeing a lot of times is that LDL, that lousy bad cholesterol, is just too high. What we're measuring in the blood is the excess that can circulate around and build up and cause harm in your body and not be good for you.
That's a good one. L for lousy. I have to remember that. I always tell my patients the L means you want that one to be low, and the H means you want the other one to be high. But now I'll talk about the lousy cholesterol. It's the L.
That's right.
So we don't want our cholesterol to be too high, but can cholesterol be too low?
This is a great question. And I think there are some people who are born with naturally very, very low cholesterol levels, that it's genetic, and they don't seem to have any harm from having really low levels of this LDL cholesterol. There are some other conditions like malnutrition and hyperthyroidism that can also cause very low cholesterol. But in general, most people who have very, very low cholesterol, it's because of the medications they're on. And it's the medications that are helping prevent them from having future heart attacks and strokes because of their risk factors. So in general, I think it's very difficult for people to have too low of a cholesterol.
Although we do need the cholesterol to be able to make the steroid hormones, which you referred to earlier. And one of the steroid hormones would be like cortisol and the sex hormones, obviously.
Yes. And so those are some basic functions that cholesterol your body makes cholesterol. But what we're talking often about with the LDL is the bad saturated fats and trans fats that you're eating in your diet when you eat animal products and unhealthy foods that is leading to buildup of cholesterol in the body, in the blood vessels. It's not the kind of cholesterol that is being used that your body is making for some of those basic functions like cortisol, which is used dealing with stress and the stress response or inflammation. Also the myelin, your body needs for, nerves and things. That even with very, very low cholesterol levels, you will still have enough cholesterol to maintain those production of those things.
So let's talk about when people should get checked. At what age should people check their cholesterol? And does it matter if they're fasting or not fasting?
That's a great question. The American Academy of Pediatrics recommends that all kids between the ages of 9 and 11 have a universal screen for cholesterol. So anytime you go to the pediatrician or a family physician between the ages of 9 and 11, you should at least have a cholesterol check then. Before the ages of age 9, if there's a strong family history or you have kind of an unusual rash with some bumps and there's concern of deposits of cholesterol, something called familial hypercholesterolemia. Sometimes we're checking cholesterols in kids as young as 6 months old or a very young age if both parents have very high cholesterol or it runs in their family. Otherwise, again, everyone between the ages of 9 and 11, and then again between the ages of 18 and 21, it's a good idea to get your cholesterol checked. If you're otherwise a very healthy person, maintain a very active lifestyle, have no other risk factors, have a normal weight and normal body mass index, getting your cholesterol checked every 5 years is probably reasonable. But for many, many Americans who are overweight or obese or who have diabetes or prediabetes, it's really recommended that they're getting their cholesterol checked every year or two, depending on those risk factors.
Now, I can see where mothers might be and fathers might be a little concerned about checking their kids for cholesterol as early as the age of 9, because they're going to feel like, okay, suppose the child has high cholesterol, now they're going to want to put my kid on medicine.
I think whenever we diagnose someone with high cholesterol, and to your point earlier, it doesn't have to be fasting. For screening, we don't need to have fasting labs. So if they come in at 3 o'clock in the afternoon, you can send them over to the lab and have their cholesterol checked. The problem is if you have high triglycerides. So if you've eaten a really fatty meal or you have a condition where you have high triglycerides, they aren't able to measure that LDL, that lousy cholesterol, and you'll have to come back and get it repeated at some point fasting. I would say if you're on medications or you've been told you have high cholesterol, it's probably a good idea to get it rechecked fasting where you haven't had anything to eat or drink for 8 hours so that we get the most accurate measurement, especially if we're talking about needing to make some changes either in your lifestyle or adding medications. You want that to be sort of as low as possible.
So definitely don't stop at McDonald's on the way to the lab.
I definitely would not recommend
Triglycerides will be.
fast food. That's where you're going to get a lot of your saturated fat and used to be trans fats and things that would really shoot up your cholesterol and give you very high readings.
Okay, so we talked about the LDL, and then we have the HDL, and then we have the triglycerides. And a lot of people are not sure what triglycerides are or why they're important. And then I think everyone knows that the LDL is the bad cholesterol. We talked about the lousy. What about the HDL and the LP little a or lipoprotein A?
I think people get really confused. You can do very detailed lipid analyses now. You can pay a lot of money for these fancy labs. Often what your doctor's ordering is sufficient. I will say the lipoprotein little a, though, is not part of the routine lipid panel and is something that is important to have checked once. Everyone should have it checked once. We recommend usually between the ages of 18 and 21, getting it checked once. It is often a genetic marker of high cholesterol. It is not something that is determined based on what you're eating, but if it's high once, it will probably always be high. If it's normal, you're probably never ever have to have it checked again. So LP little a is really another one of those lipid molecules in your blood that really is potent at causing heart attacks and aortic stenosis. So it's something that we take into account as an additional risk factor and would be more aggressive at getting people on cholesterol medication and lowering LDL, that lousy cholesterol, if they have this additional marker as well as triglycerides. So triglycerides are sort of again, something that can be due to alcohol, can be due to diabetes that's not well controlled, can be due to the thyroid, can also be genetic, can cause pancreatitis if you have very high levels, 1,000, 2,000, 3,000. If you've had recurrent pancreatitis, definitely you may have a genetic condition that's causing high triglycerides, and there are specific treatments, for lowering triglycerides. We want generally the triglycerides to be 150 or less. Generally, we want the LDL, that lousy cholesterol, below 100. The LP little a, normal is usually around 0 or less than 30. We consider elevated to be over 125 nanomoles per liter or over 50 milligrams per deciliter. Depends on your lab cutoffs and things, but it'll usually be marked in yellow if your labs are out of range. And then that HDL, that good healthy cholesterol, higher is better for men over 40, for women ideally over 50. And if you can get into the 60s, that's amazing. Most people, it's also genetic and has to do with your diet. And unfortunately, there's no good medications to raise the HDL.
Right. Now, having high cholesterol, does that automatically mean that you'll get heart disease?
I think it depends on what's causing your high cholesterol. I would say when I look at someone's cholesterol when they come in to see me, I look back at that first cholesterol we have in our electronic health record. And if it's been high for a decade or two, I would be very concerned that that person is at higher risk of having some sort of development of heart disease or hardening of the arteries. We detect that with a CAT scan, a special type of scan called a coronary artery calcium scan. But if it's a new problem that just popped up in the last couple months or in the last couple years, and it had previously been normal, then I start to look more at what are their risk factors, what are some maybe things in their diet, maybe some new medications. For women, sometimes maybe they are going through menopause and they can have a little bit of increase in their cholesterol. And then that's a little bit less concerning, I would say, than someone who's had decades of high cholesterol.
So numbers are important, but lifestyle is the foundation. You mentioned that menopause increases the cholesterol. How much can diet and exercise realistically lower cholesterol?
It really depends on how bad your diet is and how, what your baseline physical activity is. There are some people that can lower their LDL, their lousy cholesterol, 100 points from an LDL of 200 down to 100 by really cleaning up their diet. I had a patient who was a bar in Wisconsin, and ate a lot of fried foods. And during the COVID-19 pandemic, when the bar had shut down temporarily, she stopped eating all of the fried foods, and without being on a medication, lowered her cholesterol by 100 points. And it really renewed my faith in that, diet is actually a big part of high cholesterol. But I think there's a lot of times people aren't able to make as drastic changes to their diet and lifestyle. So maybe they can only lower it 20, 30, 40. It really depends on how high you're starting and how low you need to go. If diet and exercise alone are going to get you there. I still think they're super important for maintaining good heart health. We recommend, 30 to 60 minutes of physical activity every day. That's part of the American Heart Association recommendations. And then also, heart healthy lifestyle with 5 servings of fruits and vegetables, whole grains, really looking at fish and things that have healthy omega-3 fatty acid and sort of healthy fish oil and things that are better for your heart than animal products and dairy, which can have high saturated fat content.
So I'm in Maryland, as you know, and Marylanders love their crabs. And most people I talk to don't seem to realize that the crabs and the shellfish have a lot of cholesterol. So just a word to let you all know, cut out the shrimps and the crabs.
I think everything in moderation, right?
Are there foods or supplements that really help lower cholesterol? You mentioned omega-3.
There are a number of supplements. Some people take fish oil. We have a medication now called icosapent ethyl or Vasipa, which is a very highly purified form of fish oil. The doses that you would need to take over the counter, usually you need to take like 8 pills a day. And in my experience taking those, they're quite fishy. So I think it's hard to get enough fish oil through the supplements to really be of the level that we find in clinical trials to be beneficial. It's best, I think, to just eat it regularly in your diet if you can. That's where, like the Mediterranean diet has a lot of seafood and uses olive oil instead of, margarine and butter for cooking, and is definitely a healthier diet. The other supplements that some people, have looked at, going back to kind of Chinese medicine, is red rice yeast. That has been shown basically be the same as sort of the active ingredient in lovastatin. It'll lower cholesterol similar to like pravastatin. It's sort of what I consider to be a weak statin. There are a number of trials that have shown that actually it doesn't reduce cardiovascular events. It really is a modest lowering, maybe 20% cholesterol lowering. It often doesn't get people enough lowering to get to where they need. And so often people require a stronger medication.
And where we need to go is an LDL of under 100, correct?
For most people, for we say primary prevention, someone who doesn't have any heart disease, diabetes, hasn't had a stroke, doesn't have kidney disease, doesn't have a strong family history, under 100, I think, is very reasonable target for most people. We also will calculate something called the kind of a risk score. American Heart Association has a prevent risk score that we use now, looks at someone's risk 10 years and 30 years of having heart disease, use that to estimate if you're someone who's higher risk or kind of in the lower intermediate risk groups, and that helps us decide if you may benefit from being on a cholesterol medication. American Heart Association prevent risk score is over 7.5%, or we used to use the 10-year kind of pooled cohort equation, cutoff of over 7.5 or 10% in the sort of a higher risk group where you may want to be more aggressive at lowering the cholesterol.
For someone with mildly elevated cholesterol but otherwise healthy, what's your first approach?
The first line for everybody is lifestyle, making sure that you're taking a look at your diet and trying to cut back on some of the animal products is usually where you're getting a lot of the saturated fat. Your LDL cholesterol is 120, 130, maybe 140. A lot of times you can make the lifestyle changes to get it close to 100. If you're starting with an LDL cholesterol over 190 or in the 200s, that's very, very high. And that's often due to something called familial hypercholesterolemia. And often people who are starting that high, they can try the lifestyle changes, but they generally need medications as well.
Sometimes lifestyle isn't enough. And I guess that's where the medications come in. So what other factors do you consider before recommending medication besides the LDL number?
For sure, the LDL is a very important predictor of future heart attacks. We also take into account a lot of other risk factors. So the biggest risk factor is probably diabetes. So people who have diabetes as well as people who have kidney disease are also in a much higher risk group, and we're much more aggressive about getting their cholesterol below 70 if they have those conditions. And then, like you mentioned, if someone has a strong family history of heart disease, parent or grandparent, aunt or uncle who's had a heart attack at a young age, usually less than 55 for a man or less than 65 for a woman. That's pretty young to have a heart attack, and usually is a sign that there could be some genetic factor that's contributing. Or if both your parents have high cholesterol and you're a younger individual with, high cholesterol as a 20-year-old, 30-year-old, I'm usually a little bit more aggressive, even if they're otherwise healthy, because we want to prevent that lifetime of being exposed to high cholesterol and having that build up over the decades. Because often if it's genetic, they're much more likely to have heart disease at a younger age than you would otherwise expect.
So would you suggest that everyone with an elevated cholesterol that needs medication get a calcium score, maybe, to see where they are?
I think a coronary artery calcium score is a fantastic tool when you're unsure if someone needs to be on a medication. I think if someone has diabetes, and for sure people who've already had an event, they don't need to get a coronary artery calcium score. They probably just need to get on medication and get their cholesterol lower. But there's a lot of people who, the doctor might not recommend it, or their prevent risk score is in this intermediate range. And a coronary artery calcium score can be a very nice additional test to look for, we call subclinical disease. Basically, we're looking at a quick CAT scan of the heart There's no IV required. It takes about 10 minutes, and it's a very quick look to see, are there any pixels of white in the heart arteries? And there should not be any pixels of calcium. And people get confused with the calcium score. It's not actually about your calcium levels, like, when you're drinking milk. It's about the cholesterol that gets calcified, that hardens, that we see on the CAT scan. And it shows up like white pixels on the imaging. And so if you have a high calcium score, usually that's a score over 100 or anything over sort of the 75th percentile, that's really, really abnormal. And really, you probably should be being seen by a cardiologist or talking to somebody about that high score. The normal score is 0. You should have coronary artery calcium score of 0, even older age.
Now, sometimes I actually do a calcium score just to be able to convince someone to start taking medication. When I have a patient who's just resistant to the idea of taking medication and they feel like they're really healthy and they exercise and they do this and they do that, and it's always, I'll work on it, I'll get it down. And you can tell from some numbers that, it's not going to come down without a little help. So in patients like that, sometimes I'll do the calcium score because they're really surprised when they see their score, and now they're willing to take the medication.
I think it is very motivating. And I think there's also power in a 0 score. Someone who has a score of 0 probably doesn't need to be on cholesterol medication unless they have, again, one of those risk factors that is going to put them at a higher likelihood of having a heart attack, like familial hypercholesterolemia or diabetes or things like that. But I agree. I think that number and telling them what that number means doesn't mean they're going to have a heart attack tomorrow, right? I have patients with scores well into the 1000s, 1500, 2000, who can go for 10 minutes on a Bruce treadmill test and have no symptoms. It's just because your score is 105 or 200 doesn't mean you're doomed. It means we need to get you on cholesterol medication. We need to make sure that you're having a heart healthy lifestyle, that you're being seen regularly and getting all your other risk factors, addressed. And then if you are having symptoms, your doctor might order a stress test. And then from there, you might end up needing an angiogram if you continue to have symptoms that are concerning for a severe blockage.
So let's talk about the medication. What types of medications are available?
We have a lot of different medications that are effective at lowering the cholesterol. Traditionally, the ones that have been around the longest, that have the most, research associated with them, are the statin medications. The main medications that I use are atorvastatin 80 milligrams and rosuvastatin 20 milligrams. These are very potent statins that'll lower the cholesterol about 50%. So if you're coming to me and you have extremely high cholesterol, LDL in the 200s, we want to get it below 100. We're going to need that 50% lowering. So those are the medications I tend to use. If your cholesterol is lower, and you're not needing to get quite as low, you can start with a lower dose, atorvastatin 10 or 20 milligrams or rosuvastatin 5 or 10 milligrams. And then, we usually recheck the lipid panel fasting in 2 to 3 months and see if we've gotten to the number that we want. And if we haven't, then we adjust that medication. Once you're on sort of the max dose, or whatever is the max dose that you can tolerate, because some people do have some muscle aches and pains and side effects from these medications, our second line medication is something called ezetimibe or Zetia. And that blocks cholesterol that is absorbed in your gut. So if you're eating a really healthy diet, usually you won't get as much cholesterol lowering with that, but that's our second line medication generally. And then our third medication that's very effective is something called the PCSK9 inhibitors. These are injection medications, some that you give yourself every 2 weeks, some that you come into clinic and get every 6 months. These are things like evolocumab, alirocumab, and inclisiran. They're very effective. They'll lower cholesterol about 50% as well.
Very effective, but very expensive.
Correct, which is why we always start, if we can, with the pills that are cheaper and generally very well tolerated and have very much longer follow-up and research behind them.
So how do statins work exactly? And the side effects, is that fact or myth? You mentioned the muscle aches, but I think they have some other side effects.
Yeah, the statins are part of a family we call HMG-CoAce reductase inhibitors. It's an enzyme that's in your liver and in your muscles, is important for, breaking down cholesterol and in your body and things. And the side effects that are in the muscles happen maybe 10, 20% of people, depending on what studies you read, that some people just really cannot tolerate being on them. Sometimes if we switch to a different one, they can tolerate that one better. And some people have problems with all of the statin medications. And so the other side effects that we worry about with statins, sometimes some people can have a little bit of elevated blood sugar and can go on to develop diabetes a little bit sooner than they otherwise would. And then some people worry about memory and brain function. There hasn't been good meta-analyses to suggest that there's concern with causing dementia or memory issues, but that's always something that I hear about and a concern that patients have.
Does CoQ10 help the muscle aches?
I have some patients who swear by their CoQ10 and it's how they can tolerate being on the statin. The randomized control trials have not shown that it's beneficial. There's no difference in the people who take it versus those who don't in terms of being able to tolerate the statin medications. But anecdotally, I have patients who really like it. It is important for cell function and cells to be able to make energy with ATP, and it's an antioxidant. So I don't think there's a lot of harm to taking it. If people want to take it, I let them take it.
So can we look at a couple of real world examples? I'm going to tell you about two of my patients. One is a 62-year-old female, total cholesterol 248, LDL 146, HDL 77, which is excellent, triglycerides 132, but her LP little a is 143.7. And the second one is a 79-year-old with a total cholesterol of 214 versus 248, an LDL of 137, similar to the 146, and then they both have high HDL, good cholesterol. Hers is 75. And then the triglycerides are 116. So would you treat these two women similarly or differently?
Well, I think first of all, it's great that you checked a lipoprotein little a. That's an additional factor that would make me want to try to be more aggressive at treating that first patient's LDL of 146 and really try to get it under 100, if not even below 70, if that patient has any additional risk factors like high blood pressure, if depending on their prevent risk score, depending on if they have had a coronary artery calcium scan and if that score is elevated at all. But yes, having the presence of that high LP little a, I would try to get that LDL cholesterol below 100 for sure. The second patient who's a little bit older, she's 79, has a good HDL cholesterol. If she doesn't have any other factors, she's living independently, she's taking out her garbage and going to get her mail every day and is, pretty active, healthy, older,
Actually
person.
cleaning horses.
Yeah, it's
Cleaning and riding horses.
right. I mean, we don't know for people over 75 if there's a benefit of statins. We actually have a very large randomized control trial going on right now called the Preventable Study, which will hopefully answer this question. Is there a benefit of statins for preventing dementia and disability in people over 75? But as of this time, there's no randomized control trials in that healthy population. So it's really a discussion with, the patient's primary care provider and, based on their risk factors. For sure, if someone 79 has had a heart attack or stent or bypass surgery or stroke or mini stroke, I would say you want to get that cholesterol treated and lower. But in the absence of any events or risk factors, shared decision-making conversation.
Yeah, because they used to tell us that if the HDL was high, you could tolerate a higher LDL. So rather than be fastidious about getting an LDL under 100, if someone has an HDL in the 70s, you might be willing to accept an LDL of 120. Is that true?
We've shifted away from that thinking and we're really going back to LDL targets. There's less protective effect of the high HDL and really we know that LDL that is really lousy and we really want to get that lower in most people unless they really don't have any evidence of disease. I mean, this is an example. I don't usually do coronary artery calcium scans in people over 75 very often, but this would be one where if this patient had been on a statin or didn't want to take a statin anymore, you could consider getting a calcium scan and seeing if their score is 0, I would say they definitely don't need it. If their score is high, then, the question is, what are you going to do about it? I would probably just keep them on their statin if they were taking it. You don't need to do a stress test for every elevated calcium score. It's really about their symptoms and what that score is, but it's a nice tool.
So this raises the bigger issue, how we measure real risk. How do we calculate true risk? And is it the ASCVD?
These tools were all developed based on large cohort studies. We try to estimate based on the population, what someone's individual risk is, but we don't take into account all of the risk factors like family history or things like some people have autoimmune issues like psoriasis or rheumatoid arthritis or lupus and things that cause inflammation. High sensitivity CRP can also be an additional mark of disease, high lipoprotein little a. For women having premature menopause before the age of 40 or any pregnancy related conditions like gestational diabetes or hypertensive disorders of pregnancy, preeclampsia, eclampsia, gestational hypertension. These are all things that would increase your future risk of having a heart attack. Also, people of South Asian descent from India, for example, even if they don't have any other risk factors, tend to have a higher likelihood of having disease. So the risk score or the calculator just gives part of the picture and is a conversation starter. But I think that you need to take into account the other risk factors and then imaging if you have it for really deciding what is a person's goal and how low do you need to go and how are you going to get there.
And do you still do the Framingham score for individual patients?
The Framingham risk score was the sort of one of the original risk scores that was largely in Massachusetts in white men. And so we've sort of switched to this 10-year pooled cohort equation, which took into account additional data from other cohorts that were a little bit more diverse. And then the new risk score is called the prevent risk score, which is based on even more millions of Americans, includes a couple additional variables like a social determinants of health and social vulnerability. It looks at urine albumin to creatinine ratio and A1C, and also helps estimate someone's risk of developing heart failure based on the presence of some of those factors as well.
Now, can a patient go in and find out their own prevent score?
Yeah, you can just go to Google and type in American Heart Association prevent risk score or HA prevent. It's the first thing that comes up. You do need to know what your numbers are. So if you have access to your patient portal and can find your last lipid panel, last blood pressure, you can fill out, some of that information on your own. A lot of our health systems are automatically calculating these risk scores to help deciding, if people need to be on these medications and help guiding the providers.
So this has been a great conversation. Let's look at a few practical take-homes here. What's the one message listeners should remember about cholesterol?
While cholesterol can be good for the body, there are a lot of people who have poorly controlled and very elevated, lousy LDL cholesterol that is not well treated. And I think knowing your numbers is really important. If you have not had your cholesterol checked in the last 5 years, you're probably overdue. And really, you need to know what your target is. Most people, the LDL target is less than 100. For people who have risk factors or who've had disease, the LDL should be less than 70. And if you've had multiple events or you have diabetes and you've had a heart attack or stroke or kidney disease or have multiple risk factors, less than 55 is really current recommendations goal. And so sometimes that's going to take 1, 2, or 3 medications to get below 55. And so it's just important that you're getting it checked regularly. And if you're not at goal, consider seeing a lipidologist or a preventive cardiologist or somebody who specializes in these additional medications to get it to goal.
Now, just while you're on the subject of the medication, how old can you go as far as treating cholesterol? Is there an age at which you would stop treating the cholesterol?
That's a great question. I have some very active, healthy patients who are 101, 102 years old and are sharp as a tack, and if you're living independently and living well and have been on the medication for a long time, I generally would just keep them on their cholesterol medication. But when you having someone who's transitioning into a nursing home or maybe has a limited life expectancy from some other condition and they're not going to live more than a year or two, at that point, the benefit of the statins in preventing heart disease is not as great as someone who you think is going to live a long life. So I think depends on the person. There are some very healthy 90-year-olds and some very unhealthy 50 and 60-year-olds. So it just really depends on what their other risk factors are.
And their liver function, I would imagine.
Yeah, liver, we didn't talk about. That is another sort of side effect of some of these cholesterol medications, that they can raise your liver function tests. We don't routinely measure liver function tests anymore, but if you know that you have a little bit of elevated or abnormal liver function tests at baseline, it is something that's important to get followed up on. And if they go up 3 times more than the higher value on the test, then we usually would stop the medication and have you get that checked out and try other medications, because we don't want you to have abnormal liver function from these medications.
So when someone is told that they need medication, what should they ask?
I think the first thing is knowing what is your cholesterol numbers, and ask them what you can do to get that cholesterol down, and when do you need to get it rechecked again, and sort of what are the next steps if it's not at that goal that you need to get to at that next check, and how long has it been high. And I think being an advocate for yourself is really important in today's healthcare environment, where visits are very short and clinicians have a lot of different things they're trying to make sure that you're up to date on. Cholesterol is something that you need to take charge of, and know your numbers and know where you need to be, and advocate for getting on medication if you need it to get to where it needs to be.
So, Dr. Benziger, thank you so much again for joining us and breaking down such a complex topic into a clear, actionable advice. For those of you listening, remember your cholesterol numbers are just one part of your overall heart health. Lifestyle changes matter, but medications can be life-saving when used appropriately. Talk with your doctor, ask questions, and take charge of your health. Until next time, stay well and keep your heart healthy. Thank you so much for coming, Dr. Benziger, and hopefully we'll see you again.
Sounds great. Thanks so much for having me.
Thanks, as always, for joining me on Wellness and Wisdom. Today, we had the pleasure of talking with Dr. Catherine Benziger, a cardiologist who is also a preventive cardiologist, in the sense that she has a master's in public health and preventative medicine, like myself. And so, being a cardiologist and someone who's interested in prevention, she was able to give us a lot of insights into why we need to manage our cholesterol. So here's the bottom line. Cholesterol isn't just a number on a lab test. It's a window into your future health. By taking charge of your cholesterol, you're not just protecting your heart, you're giving yourself the chance at a longer life, a sharper brain, and the energy to truly enjoy it. Small steps today, whether it's lifestyle changes, having the right conversations with your doctor, or starting treatment when needed, can pay off for decades. Your heart, your brain, your quality of life, they are worth it. Once again, thanks for joining me. Please subscribe. And if you have someone you love, send them this podcast so they can educate themselves about cholesterol and the importance of managing it. Bye for now. Until next time. Bye.